Maybe if I put more lights, or that okay?
Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Today, for our last session webinar of the weekend, we have a very, very, very esteemed colleague and friend of ours that will be presenting on integrated aesthetics in periodontics and implantology. Quite excited about that. Welcome, Dr. Alaa Abu Shareia.
Thank you.
So before I do a formal introduction of Dr. Alaa, I'd like to go into the housekeeping stuff. At the end of the session, there will be a link on the side in the comment section where you can register to get your CE, the 1 hour CE for the session. And you can post your comments and questions on the side as well. Number one. Number two, on my left, probably your right, you'll see a QR code that will take you to the top 100 doc website where you can nominate any doctor from any healthcare industry that would like to come on a webinar and has something to offer for other doctors to benefit from. Please feel free to join us in that sense. Also, we are in the process of soft launching the Doctorate of Healthcare Business, the first of its kind endeavor, to increase the business acumen of our colleagues, so they're not taken advantage of by all these third parties and these corporate interests as part of the doctor-to-doctor movement. And continue to join us. We are all about education and work for doctors. And the Institute, the Global Summits Institute, is off by and for doctors. So it's time that we get our authority back in our own industry, and that we exercise autonomy, which is a very important principle of medicine and healthcare. With that said, let's read off Dr. Alaa Abu Shareia, and let's discuss his background. He has a very exciting resume as an oral surgeon. He was born in '74, and he is married and has 2 girls. I also found out in our discussion in the green room. So a family man, beautiful family man. He's graduated as a medical university doctor in 2000 at Safarik University, Faculty of Medicine, branch of stomatology in Slovakia. Then he went on to expand his stomatology practices with the EU board, then successfully completed a full rotation for oral and maxillofacial surgery and specialized in dental surgery in the year of 2007. So a long time practicing oral surgeon. Lots to be learned from Dr. Alaa. Then he completed his master in clinical program in oral implantology at New York University with the ultimate professional achievement in implant dentistry to pursue excellent status for membership in the Academy of Dental Experts at the UNIMES University in Santos, Brazil, as well as periodontology from Camillus Uni in Italy. Wow, so you have been around all of the circles. One of the top doctors in the world in the IPFR, APFR, and CGF with sticky bone, as well as mesotherapy techniques, implant courses in cosmetic zone, pterygoid implants, interesting topic, minimum invasive sinus lifts, and over 20 years experience of working as a dentist, dental alveolar surgeon, periodontologist, and implantologist with full registration license in Slovakia and General Dental Council in UK. I mean, it would go all day long for me to read your credentials, doctor. You also achieved Best Dentist Award from the IEA and the British Dental Award from 2020. You were a top doctor of January in the class of 2020, most voted doctor award, most respected doctor. There's so much to be learned from you. Thank you so much for coming on and contributing your time today.
I appreciate it. Thank you very much, Dr. Shah.
So what is the motivation of someone like you who goes through dental school, comes out, does oral surgery, goes into perio, goes into implantology, travels the world and lectures, does hands-on courses? What motivates you? What is the ultimate goal?
The most important thing, Dr. Shah, and for all the colleagues who are listening to us now, that we need every day to share the information. We need to be in contact together. And this is the way how to help and to improve the medicine. It's not only just, I know these techniques, I know these methods, so I keep it for myself. It's something like to share. We need to learn. And every day we are learning something new. So from AOS now, I can say that every lecture has been gone through until now. We learn a little bit, we learn something new, we learn something can help in our practice. So that's the main thing, like to share with everybody.
That's lovely. So love one, you learn one, and then you do one, and then you teach one, and around the circles we go. That's very interesting that you take it. Someone as knowledgeable and as with so much expertise as you has the ability to learn from others on a daily basis, come to these webinars, share, and I know your time is extremely valuable. So Doc, tell us about, this is an interesting topic, aesthetics and perio and implantology. I don't know how many times I placed an implant in the past and I ran into aesthetic problems, especially periodontal, gingival, where I had to make modifications. Actually, I have one case going on right now that I am unable to get this patient to have erythema and other things on the gingival gum, although the implant was placed lingually. So I'm excited to hear more about your way of addressing the aesthetic issues pertaining implantology. So tell us a little bit more about your topic and where you come from with this.
Well, actually, I choose this topic from the point of view that the cosmetic zone, always we have a problem with the buccal bone. Actually, the palatal bone, we can manage it, but the buccal bone is the main problem, the main issue in the cosmetic zone. So if we do that techniques, okay, which I'm gonna talk about it now. Maybe I'll divide my lecture in a part of like theoretical part. First of all, I need to explain the principle of the GTR and GPR from the periodontics point of view. Then I go for the implantologist point of view. So in this case, we can discuss the part which we can avoid the complications to happen later on. That's the main target of this presentation. So,
because you and I both know a lot of the complications end up with having to back that implant out, start over, have the patient go through all that process again, or there's no really way sometimes to fix the problem.
And we know from the periodontics point of view that we have peri-implantitis later on. So how we can avoid also the peri-implantitis? So we need lots of things to discuss with the colleagues, with the patient, so to reach that level where we have a good result for us and for the patient.
That's lovely. We appreciate your time and your contribution. With that said, Doctor, I look forward to sitting here and myself learning something new today. Thank you so much. With that said, please proceed with your presentation.
All right. Okay, here we go. Integrated aesthetic in periodontics and implantology. Okay. So I'm presenting the educational dental of medicine company. It's my practice in Banska Bystrica. It's in the center of Slovak Republic. The term soft tissue integration describes the biologic process that occur during the formation and maturation of the structural relationship between the soft tissue, the connective tissue, and the epithelium, and the transmucosal portion of implant. The dentist cannot always influence all the situation. In comfort with the find the situation in the hard and soft tissue losses have already occurred. At this point, it's necessary to act in a goal-oriented way in order to regain the lost tissue, and tissue around the implant must remain vital. Furthermore, when an inadequate quantity or quality of the soft tissue is available to secure a stable pre-implant environment, the implant surgeon must know the principles and techniques to successfully reconstruct these complements. Guided bone regeneration, we say GPR, and guided tissue regeneration, we say GTR, are dental surgical procedures that use barrier membranes to direct the growth of new bone and gingival tissue at site with the insufficient volumes or dimensions of bone or gingiva for proper function, aesthetics, or prosthetic restoration. Guided bone regeneration typically refers to the ridge augmentation or bone regenerative procedures. Guided tissue regeneration typically refers to regeneration of periodontal attachment. Guided bone regeneration is likely or like guided tissue regeneration, but is focused on development of hard tissues in addition to the soft tissue of the periodontal attachment. At present, guided bone regeneration is applied in the oral cavity to support new hard tissue growth on an alveolar ridge to allow stable placement of dental implants. When bone grafting is used in conjunction with sound surgical technique, guided bone regeneration is a reliable and validated procedures. Let us talk now about the augmentation materials. The augmentation materials used are autografts like tissue transfer from same person, allografts, tissue from genetically members of same species, other materials available, xenograft, tissue donor from other species, and autogenous bone. We say like the gold, what the patient has. Note, when the bone density is quite low, the resorption of the grafted site in these cases can reach up to 30% of original volume. Studies comparing autogenous bone and bovine bone mineral in vertical bone augmentation failed to demonstrate significant differences between grafts in terms of bone gaining. Further study assessed the using of bovine bone graft in combination with autogenous bone to decrease the resorption rate of the graft, to increase the long-term stability of the regenerated tissue, and to reduce the morbidity associated with the extraoral donor site. Now we will talk about the membranes. Barrier membrane is utilized in GBR technique to cover the bone defect and create a circulated space or isolated space, which prevents the connective tissue from growing into the space and facilitates the growth priority of bone tissue. An added benefit of the membrane is that it provides protection of the wound from mechanical disruption and salivary contamination, and GTR as an alternative to resective surgical procedures to reduce pocket depth. Barrier membrane criteria should be as follows. Biocompatible, excludes unwanted cell types, allow tissue integration, creates and maintains space, provided the structure is easy to trim and place. Now, currently there are two types of barrier membranes available. We know non-resorbable membrane and resorbable membranes. We talk now about the non-resorbable membranes. The main types are the EPTFE and the DPTFE and the PTFE, which is titanium. So consequently, the EPTFE membrane act as a barrier to soft tissue and speed up bone healing, which took place between 3 to 6 weeks. The biological method of osteopromotion by exclusion is good for predicting ridge growth or defect regeneration. On the other side, we have the resorbable membrane. There are many different types there, like the main, which it is polymers and the natural biomaterials. Synthetic polymers are such that is polylytic acid bilayer or the collagen-derived membranes. These membranes have been shown to significantly improve probing attachments level to 1.1 millimeter and periodontal packet depth reduction to 0.9 millimeter when compared to placebo or control materials. Resorption rates ranging from 6 to 24 weeks depending on its different chemical structures. There is no need for a second surgery to remove these membranes. This will prevent any disruption to the healing process of the regenerated tissue. These are the results obtained based on randomized clinical trial done to compare the stability of augmented bone between a synthetic resorbable membrane and a collagen membrane with the guided bone regeneration stimulus with the dental implant placement in the aesthetic zone in terms of facial bone thickness. The main of these procedures is to integrate and describe the aesthetic in periodontal and implant therapy about some cases. The simple idea behind this presentation is to avoid unnecessary tissue loss from the very beginning. This results in a win-to-win situation for the practitioner as well as for the patient. Recently, we suggested a novel surgical technique for the treatment of challenging infraboni defects when gingival recession is an aesthetic concern. By creating a stable soft tissue wall, this technique allows to compensate for the lack of bone support, reaching both biological and aesthetic clinical success. We'll start with this case now. Case presentation here, we briefly, in this case, I'll discuss 55 years old patient, healthy, was referred to my clinic with a periodontitis, chronic inflammatory disease of the tooth supporting structure, mobility grade 2 to 3, interdental pocket depth 4 to 5 millimeter and more, hypersensitivity, periapical lesions after taking the OPG, CBC and option has been discussed with the patient as well as the medical history. Patient agree for the extraction option and full upper jaw rehabilitation, all on 6. Immediate implants after the extraction, not to do it on 2 stages, two-stage technique. We done it on 1-stage technique, immediate implants. Integrated with the use of GPR and GTR, patient has been recommended to be without a provisional at least for 3 months until the taking of the impression for the final prosthesis. Here the treatment plan, and after we see the OPG, we see that there is low sinus on the both sides. Small level, there is some periapical lesions after root canal treatments, hypersensitivity in the other teeth, and we start our operation by anesthesia was applied for the full upper arch. Horizontal incision is carried out. Then extending one to the mesolean distal from the infraboni defect. Full thickness trapezoidal flap is then elevated, and the remaining facial gingiva is deepithelialized with atraumatic surgical extraction for all the upper teeth. I would like to stop here for a minute using the talking about the sticky bone. Using of the sticky bone from the extracted teeth or from the various bone materials as one of the options we have if we don't want to use any xenograft or allograft or any other materials. And this is coming from the teeth of the patient. After the extraction, we can trim it down in some special machines, and with the disinfectant. After that, we can use the IPRF after taking blood from the patient, and we separate the IPRF and the APRF. But in this case, I use the xenogenic debone graft material from non-human individuals. It is most used as perfect substitute for autologous bone graft. At this level, I'm using mix of the graft with the IPRF. This is the machine, and on the right-hand side, we see the machine for mixing the bones. Sorry, the teeth. And after we remove the teeth, after grinding it, then we can use it for the sticky bone with the IPRF, which we can have something called the sticky bone. But in this case, I continue, as I mentioned here, with the debone graft material derived from non-human individuals. Now, platelet-rich fibrin, the PRF, belongs to a new generation of platelet concentrates with simplified processing and without biochemical blood handling, leads to the intrinsic incorporation of platelet cytokines and glycokyne chains in the fibrin meshes, which it is called the APRF, which is here. The result of the present study suggests that in the histological evaluation, because of its biological compounds, PRF results earlier vessel formation and tissue maturation compared to the connective tissue graft. This my table is ready now with the IPRF and APRF and ready to be used. Now, here we start. The defect is degranulated and the socket has been scaled and cleaned with the bezo surgery, which I use a lot in my practice, and also with the HIPSE when we do sinus lift minimum invasive. Also, we use this bezo surgery. But here, the treatment of this condition is largely based on the removal of the local factors and restorations of the bony architecture. The buccal flaps, periosteum is dissected because we do full thickness flap, and the flap is mobilized and coronally advanced to a level more coronal to the CEG, equalized for alveolar architect. Then on the right-hand side picture, I do the egalization, like to smooth the bone and to make it all in one level. And here we see on the left-hand side, this socket is now conditioned with the EDTA gel and drains with this saline solution. An enamel matrix protein gel is applied into the defect, and tension-free primary closure of the interdental papilla is achieved. Like we know exactly the place of the papilla, we saved the papilla and the whole periodontal structures. Nowadays, we have also the digital to go for, but here I would like also to show that we have also the parallel direction plan of implant insertion. Like if we don't want to go for the digital and the rest of the work with the lab, simple and easy. We'll come to the periodontal part here. Full thickness soft tissue graft was taken from the donor side palatally on both sides. You know, we know that we do soft tissue graft. Already we have the gold tissue which the patient has. So we took the graft from there and we need to replace it on the buccal bone to have good results. Here showing the stability of the implants, direction of the implants, and making X-ray during the surgery. The ISQ showing the stability of the implants. Then we are using the torque to give us the high torque and to be sure that everything is as it's supposed to be. Inserted implant with the zone of label buccal dehiscence, and we have the implants now done, replaced. So we go for the second level. Bone augmentation of sticky bone, mixed of autograft and xenograft. By the way, one of the things I would like to mention here, during the drilling, maybe some simple small information, but it has good results really. I do the drill without water, which I can collect the whole bone during the work, and I add it to my xenograft to get more autogenous bone, okay, to replace. And this we are mixing with the IPRF, and this giving really good results. Now we see here. Bone augmentation of sticky bone, mixed of autograft and xenograft with IPRF, made from the blood of the patient, filling the resultant cavity and covered with the soft tissue graft taken from the donor side, which is free gingival graft, and all covered with APRF on the immediate healing cap of the implant. Here I would like to explain about the APRF. We can use the APRF as itself to be replaced on the top of that, of the grafts, but we can use the poncho technique where we can replace the healing cap inside the membrane of the APRF, and we replace it on the top of all to make a membrane for our work. CBCT and 3D post-operative, checking all the position. Now, finally, adaptation of the flap and fixation with structures. With sutures. The vertical releasing incision are closed with the interrupted sutures and internal horizontal matrix sutures. Of course, when I do such like these kind of surgeries, I always give post-operative medication Mainly, we give the augmentin, for example, like 1 milligram every 12 hours. And sometimes when we do such like this big surgery, we do like, we recommend some anti-edematous and some painkillers. Mouth wash and rinse from the next day, and recommending also the diet for until the time for removing the stitch. Uh, this picture is 2 weeks after the after the surgery post-operative. But I would like to add here that according to many references, 50% of implantological treatments require combining augmentative procedures. We can see on the buccal side how we have that thickness which we looking for. Patient after completing of 3 months post-operative. Now we can see the healing caps, and now patient is ready for the impression to be taken. On the right hand side, we can see how nice gingival margin we have. I usually replace my implants around 1 to 2 millimeters beneath the bone. And this is the gingiva and the keratinized tissue which we need to have, and we are ready for the impression. Labs work is done. Now patient after 3 months, now it takes maybe first visit, we do like the bite registration, then we check the try in, and this in the day of the fit in, we fit the abutments in the right position and the bridge fitted in. I usually also take post-operative OPG after the cementation to be sure that all the screws has gone through and the position of the bridge is in the right position. No any cement left, because this is one of the contraindication around the perio, around the implant. For the lowers, for porcelain bonded bridge done on the lower teeth after completing 4 periodontal treatments for him. And at the end, there has also been big change in the patient's appearance, and he continues to be happy about long-term stability of his implants treatment outcome. So, to avoid these complications with the upper implants and the lower teeth, regular scale and polish every 3 months was obtained by our dental hygienist. If we look on the left-hand side with the lower, we have teeth, this tissue collapse of the gingival fibers that separates the lesion from the alveolar bone, and we can have more plaque. And in this case, we recommend also that deep root planning and good cleaning. For the uppers, we have the implants, and definitely if we don't look after our implants, definitely we will have peri-implantitis, and the inflammatory infiltrates in 2 to 3 times the size that of the periodontal lesion and reaches the bone. So several surgical techniques via GPR have been proposed regarding the 3-dimensional bone reconstruction of the severely resorbed maxilla using different type of bone substitutes that have regenerative, osteoinductive, or osteoconductive properties, which is then packed into the bony defect and covered by resorbable membrane. Moreover, in the era of modern dentistry, successful implant therapy often requires sound osseous support. When an inadequate quantity or quality of the soft tissue is available to secure a stable peri-implant environment, the implant surgeon must know the principles and techniques to successfully reconstruct these components. Take-home message: GPR and GTR are sensitive operator technique, and the important factor of the success of these kind of surgeries is the level of the experience and the skills of the operators. New learning means theory, practice, and repetition. Thank you all.